lot of the published data up to more recently has been looking at sort of cohorts of patients that are mixed. So newly diagnosed and recurrent, throwing in some other tumor types, meningiomas, high grade and low grade, and sometimes the publications are sort of lumping the outcomes from all of those different patient subtypes. And so it's been really hard for us to see just how effective is this therapy in sort of our bread and butter, GBM, IDH wild-type. And so we really wanted to look very, very diligently at this group. And so we went into the registry and pulled out just those that are IDH wild-type, GBM. We selected any KPS adults and with a couple of years of follow-up. And our intent here was to have the largest sort of experience that we could glean the best sort of outcomes data. And so we collected data from 14 centers from January 2016 to May of 2019, and again, looking at overall survival, PFS, and then procedural related outcomes. And this is the consort diagram from this. I just want to spend a couple seconds on this. Oh, wow, it's small. There were about 117 patients in the registry. We excluded the IDH mutant tumors sort of off the bat. But then we had a cohort of patients that were sort of IDH unknown, so that just wasn't collected or wasn't recorded in the registry. And so in order to try and increase our numbers, what we decided to do was to take any of those IDH unknown and take patients who were older than 55, where the incidence of IDH mutation is exceedingly low, like it's less than 1% in that patient cohort. So that helped us to add another 11 or 12 patients onto that cohort. So we think this is a pretty good IDH wild-type cohort of patients in this group. And so we had 89 total, 60 recurrent, and 29 newly diagnosed, with pretty typical, age and gender distributions and baseline KPS. KPS was a little worse, a little lower in the newly diagnosed, and in the recurrent disease, the tumor volumes were a little higher, but a pretty good consistent group across both cohorts. What was also asked in the registry is sort of what is the indication, what was the reason for choosing LITT for that particular patient. Most patients, it was sort of a non-resectable lesion, so that's kind of where we think about LITT having a major impact. But what's surprising is in both groups, newly diagnosed and recurrent, 40% of patients, it was reported that a minimally invasive procedure was preferred. And we don't know exactly who preferred that, whether it was the patient or the surgeon, or that was a conversation that they had that led to that. But I think this is a kind of an important thing as we think about and talk to patients about LITT and its potential benefits. In terms of procedural outcomes, outcomes were, in terms of safety, were pretty minimal. There was about a 13.5% device procedure-related adverse events. Most of these were transient, cerebral edema-related, and resolved within 30 days. And as we mentioned, one of the benefits, of course, of the procedure is sort of relatively quick discharge from the hospital, and so the median length of stay for this cohort was 50 hours. In terms of the outcomes, if you look across the recurrent disease, the time from diagnosis to death was 27 months, which is pretty long. So it is possible that this cohort of patients was doing pretty well. But from the time of the procedure to death was about 9 months, which is right in line with what you see with standard of care. It's in line with what you see for most clinical trials. So I think this is really good evidence that this approach is effective. In the newly diagnosed, we had a bit of a surprise because the time from diagnosis to death was around 9.5 months, which is pretty short. And so what we did is we dug a little deeper into the data, and what we found was that a lot of those patients didn't actually get treated or didn't get standard of care after the procedure. And so when you look at the cohort of patients who did get chemoradiation, as you would expect, the median survival looked very consistent with what you see with standard of care after craniotomy. So I think there's a lot of really important points and things to kind of delve into as we think about it. And these are the Kaplan-Meier curves for newly diagnosed and recurrent. Again, 40% at 12 months, and then 60% at 2 years, which is really, I think, very strong data. So again, switching gears, we always think about LITT in terms of extent of ablation, cytoreduction, but there are also other potential benefits. And there are two key ones that we think about, that we might know about. There's probably others that we don't know about. One of them is breakdown of the blood-brain barrier, which can help with drug delivery, for example. And then the other is its impact on the immune system. And so ablation can really release neoantigens. It can disrupt the barrier. It can help attract immune cells into the tumor microenvironment. And there may be other impacts of hyperthermia on. This is some of the data from Eric Luthart's group looking at blood-brain barrier, blood-brain tumor barrier, and showing that LITT induces increase in vascular permeability, which can last for upwards of 4 weeks, and in some preclinical models able to demonstrate sort of synergy with chemotherapy and greater delivery of chemotherapy and improvement in animal survival, as you can see in this study here. And then in terms of the combination with checkpoint inhibition, this is the data from SNOW from a year ago. Again, Eric Luthart's group, Jane Champion was the first author on that study, showing that LITT with Pembro was led to longer overall survival compared to Pembro alone, sort of a doubling there, as you can see. And then if you compare it to historic LITT controls, Pembro plus LITT looks a little better than just LITT alone, and then certainly a little bit better than standard chemotherapy. Again, historical controls for comparison there. So I think there's a lot of excitement. I know I certainly am, and we have some really interesting ideas in terms of how to integrate LITT with chemotherapy, but also LITT with immunotherapy. And you can see here there's multiple trials with LITT and chemoradiation, or LITT with checkpoint inhibition. And as Peter said, hopefully there'll be some papers published in that arena soon. So with that, just kind of summarize quickly, very strong safety, and I think really great efficacy data from non-randomized trials. There's a growing body of evidence for glioma, but also for recurrent brain mets, which you'll hear about from Dr. Fetchy soon. And then LITT's a great tool. Obviously, if a patient's going for a biopsy, they can get LITT afterwards, again, depending on what's seen at the time of biopsy. Great hospitalization data, very low rates of side effects and device-related permanent adverse events, and a real opportunity to use this as a tool, particularly I think for patients that aren't trial eligible, patients with deep-seated tumors, poor KPS, and the other indications that we mentioned. So thank you very much for participating.